Good evening, everyone. My name is Julius, and I'm a medical student at the University of Central Lancashire. And today I am going to be talking about adalimumab versus novel rheumatoid arthritis therapies. And actually, I'll be exploring the clinical efficacy trials that have been done, and also look into a real-world outcome. And let's begin. The picture behind me is of a rheumatoid arthritis, and this is what happens when the complication occurs. So I begin with a question. As the healthcare system grapples with the rising cost of living and chronic conditions of all sorts continue to burden the society, the introduction of high-cost biologics raises the questions: who benefits most? And can a monoclonal antibody really alter the rheumatoid arthritis treatment, not just on the clean, controlled trials, but also in a complex reality in a clinical practice? And what does the real world tell us? From corticosteroids and methotrexate to a fully humanized monoclonal antibody, this is the therapeutic journey of rheumatoid arthritis. So again, that's the image of somebody who has rheumatoid arthritis, and we will discuss what happens. Rheumatoid arthritis. Let's take a look at what happens and why the need for a targeted therapy. Rheumatoid arthritis is actually a chronic condition which is autoimmune, and it occurs when the body immune system mistakenly attacks the joint lining, leading to inflammation and joint damage. For a major reason, adalimumab is a drug that was discovered or approved in 2002 and is used to block the tumor necrosis factor alpha, because the tumor necrosis factor alpha here becomes a very key player. It is a signaling protein that actually is involved in amplifying the inflammation. So let's move further and see what's the prevalence. The prevalence of rheumatoid arthritis is increasing, and the current data shows that it is affecting 1 in 100 people globally, and it causes persistent pain, joint swelling, loss of function, and actually beyond these symptoms, the other aspect of it is that it has issues to do with loss of productivity and the overall quality of life. And this socio-economic burden is in a lifelong treatment becomes really very, very significant. What are the symptoms of rheumatoid arthritis? Clinically, the patients will present with symmetrical joint pain, and this pain, sometimes they complain it lasts for more than 30 minutes and more so in the morning, and it is accompanied by, fever, low-grade fever, and also some progressive joint damage that can happen, but this symptom actually occurs gradually, so you may not notice until it is on the late stages. So what are the treatment strategies? Traditionally, the treatment has been always methotrexate, but now the world or the new advancement is moving away from this drug, because ideally methotrexate works by suppressing the entire immune system, but the newer biologics and like the drug we are talking about, adalimumab, they seem to target just specific areas or specific signaling molecules. And even more, some advanced drugs like JAK inhibitors, they actually target several signaling pathways, and one of the drugs is upadacitinib, and this also actually makes the drugs more effective and more beneficial to the body. As we all know, and as I said, monoclonal antibodies are actually the shape of a human the shape of a human antibody, and this is seen in that image up there. What is the mechanism of tumor necrosis factor alpha? The mechanism of tumor necrosis factor is very interesting. Actually, it acts like a fire alarm in rheumatoid arthritis, telling the body to keep on attacking the joints even when there is no threat. And scientists have actually discovered that a drug called adalimumab can target this tumor necrosis factor and block by binding to its receptors, and thus reducing the cytokine release. And this actually is what reduces the inflammation and halts the, like it halts the destruction of the joints. And this is the major problem that has to be targeted when we are thinking about the treatment. However, some, like as you see on this image, the tumor necrosis factor alpha, this one, and it is being blocked by a monoclonal antibody, adalimumab, and the target is the TNF receptor. So once this blockage happens here, the interaction from this receptor actually neutralizes it, prevents it from attacking the tumor attaching and interacting with the tumor necrosis factor. And this is the solution for the inflammation. Let's move on further, and I took on to a preclinical study that actually compared adalimumab versus zolaritumab, and the idea or the aim was to try and understand which of the two drugs between a nanobody that is trivalent with a smaller molecular weight can compare with adalimumab, which is a monoclonal antibody and has actually a bigger or a heavy weight in terms of the molecular weight. So this study used a mouse model of collagen-induced arthritis, and the drugs were tested on this model. But after the investigations, it showed that ozoralizumab had a faster and more distribution in the joints compared to adalimumab, because of its molecular weight. And actually, at the end of the study, the results were really proving that ozoralizumab was more efficient in terms of biodistribution. But in this type of model, there was an issue with the species-specific differences because of the tumor necrosis factor alpha not able to bind specifically on the mouse model. And another research was done, and it suggested the use of transgenic mice models that actually overexpresses this tumor necrosis factor and gives a better result. So moving forward, another study was done, and this was a select compare study done to evaluate upadacitinib and adalimumab. Upadacitinib is actually a JAK inhibitor, and they wanted to do a head-to-head comparison between tumor necrosis factor blockers and JAK inhibitors and find out which one has a better response. And at the end, the results achieved that upadacitinib had a 70% remission on the patients, and compared to adalimumab's 61%. Although the upadacitinib had a more effective remission, it had a risk of infection, and this actually is what brings the question, why would a very good drug bring issues with infections? And it made me to look further into a real-world situation and what happens actually in a real-world setup. And in real world, most of the time in practice, many patients are switched from adalimumab to biosimilars for cost reasons. And sometimes like the medicine adalimumab is really expensive. In the UK, it costs around £40,000 per year for one person, and this makes the cost so expensive unless someone has a complete cover for this treatment. And some of the real studies done by Nabi and others indicated that there were no difference in the outcomes comparing adalimumab and some biosimilars, but Taylor, on the other hand, had suggestions or discovered that these biosimilars had a lower control, and they also had adherence issues, making the biosimilars not a very good choice in terms of control. And the disease activity in adalimumab actually was 68 compared to 26. And this, we are talking about the remission percentage of people who go into remission when they are on adalimumab as compared to those who are on biosimilars. And actually, a real-world decision making is really complex, and it brings us to the question that we ask ourselves: who benefits most in these types of switching the drugs, and what does the real world tell us? So the real world is concluding and telling us, or showing or indicating, that these decisions are beyond the clinical data that has been recorded. And in conclusion, this adalimumab seems to have remained moderately efficient and effective and a stable therapy for rheumatoid arthritis. Although it has a slower joint penetration than newer biologics, its long-term data is quite reassuring. Upadacitinib, on the other hand, shows efficacy, better efficacy, but it comes with higher risks of infection, and switching to biosimilars should be actually really individualized, considering both clinical and patient-centered outcomes, and ongoing research actually is being needed, or is needed, to improve delivery of these drugs, and head-to-head comparisons of the, like preclinical studies like what we had discussed before, and tracking of the safety of these drugs. So these are the references that have generated this article, so you can check on your time and read about the study. And yeah, if you have any questions or comments or contributions, I can welcome them. Thank you for listening to me, and have a good time.